I have to say, parenthetically, one is it's a great honor to be speaking at this memorial lecture, but also to you in that I kind of look to these types of institutions, community teaching hospitals, to be our future and not, and you'll think this is a bit strange, I'll say that the academic health sciences complex, my hospital is probably the largest one in Canada, is going to be challenged in the next little while. And I think you're much more positioned to be successful in leading the new charge in healthcare delivery. And I'm going to try and explain that. So I'm here to say thank you very much, but also to challenge you a little bit as to be the leaders in this new next horizon in healthcare delivery. You're a health center, and I think that name was probably chosen very deliberately. It's not a healthcare center. It's not a hospital. You changed the name from a hospital to a center. And those aspects position you uniquely to serve your community, focusing on the promotion of health and well-being, but also looking after illness when it arises. We've heard a lot about our healthcare system. We'll start up high. Is it sustainable? And people talk about that because generally the growth in our expenditures on health are going up about 7.2% per annum. Now that's until the last couple of years, and I'll explain that in a minute, but that type of growth was we've never recorded growth like that in the healthcare sector before. Our revenue streams from a government perspective are growing about 3.5%. So you can imagine if you're expending 7.5% and you're getting income in, revenue in at around 3.5%, the money's going to have to come from somewhere else. And I'm going to explain that in a minute. But that's why people think that that growth is not sustainable. In Ontario, it's about 43% of our total budget goes to healthcare. And when you've got a $12 billion budget deficit, where do you think they're going to start looking? It's not going to be in the other areas. It's where 43% of your budget is. So we should anticipate that our growth is going to be in health, as our Ministry of Health is projecting, just over 2%. And at the moment, they're tracking around 2% growth. So what does that mean for us as healthcare providers? So that's why people are talking about healthcare being unsustainable. It's because of its growth. I would argue, on the other hand, I would agree that it's unsustainable. I don't think that that's the reason, however. I think the reason is quality. And I'd have to say that whereas we all think that we have a fantastic healthcare system, and this is, as we've been led to believe, this is the healthcare system that's the best in the world. But when we objectively look at our healthcare system compared to other countries, whether that be through the OECD comparative studies or the Commonwealth comparative studies, if you look at how we do, we're about middle of the pack in most parameters. But in fact, in patient experience, which is another word for access, we don't do very well. Matter of fact, we're in the lower 1/3. In safety, we're in the lower 1/3. So we're middle of the ground for most parameters and below in the lower 1/3 for two very important parameters. The net result is when you look at our expenditures, $211 billion in Canada per annum, $6,000 per person, 11.3% of our GDP going to health. We're the 6th greatest spenders on health, privately and publicly. And we have an average to slightly below average productivity. So the net result, value for money, when you look at the Commonwealth study, we were last. When you looked at the OECD study, we were second to last because the Americans were included in that study. So the net result is, I think it's unsustainable because taxpayers are going to start to say, we're putting a lot of money into this healthcare system, and we're not getting the results that we would expect. Now, one other thing I think you should know is that we used to be, 10 years ago, we used to be within the top 5 in terms of life expectancy and infant mortality rates. We're now 20th. We're dropping dramatically down. And I'm going to try and propose a reason for that in a minute or two. So I think that if you look at international comparators, we have a good healthcare system. There's no doubt about it. We have a very good acute care healthcare system. We just don't have a very good chronic disease management system, home-based care system, or public health system. And we pay for that dearly. So that's why I think healthcare is unsustainable. And I think the challenges that we're going to face in this next little while is to improve quality, contain costs. And we're going to have to start thinking of very transformative changes in the way we do business. We have been exceptionally good at treating those illnesses that used to cause people to die. Stroke, heart disease, a few of those things. And that's because of the hard work that you folks do on a regular daily basis. The trouble is, that's led people to live longer and with chronic diseases. Add in a few things like diabetes and obesity, and you can see that chronic disease management is the issue of the day. And so how we struggle to manage that and how we deal with that is going to be the measure of our success in the future. My patient that I saw 15 years ago was on 3 medications. They're now on 15. They used to have a chest x-ray and a CT. Now they've got chest x-ray, CT, PET, MRI. And the question is, are they a lot healthier because of that? Everybody would recognize that we have to start to think putting patients more closely in the center of the discussion. We have to deal with this new paradigm of chronic disease management. What we've done is healthcare has changed dramatically, and health has changed dramatically, but our healthcare system is still a legacy system that we've tried to tweak, and as a result, it's inefficient and ineffective. What is it about inequity, and why would I be standing up here as a physician talking about that? So there's a thing called the Gini index. That's the gap between the rich and the poor. We're at 0.32. That puts us square in the middle of the pack of industrialized countries. So I'd say that's okay. We're not huge inequity. We don't have zero inequity. There's countries better. There's some that are worse. The thing about that is our growth of inequity in Canada is going faster than any other developed country in the world. We're winning the race to the bottom. And as a result, I told you, remember, that you're starting to see life expectancy, infant mortality rates we're going poor in that regard. That's because if you look at those areas of people who are not living long or having high incidences of infant mortality, those are people who do not get the same access to meaningful health services delivery. That's because of inequity. And inequity, as it grows, I'll explain in a minute, it's socially not a good thing. It's not part of our principles in Canada. That's not what we believe in. However, at the same time, it's hugely expensive. We cannot afford not to deal with this problem. It's going to bankrupt us. So growing income inequity, which I've explained, leads to growing social inequity, and as a result, growing health inequity. So what do I mean by that? And I'll see if I can explain it. The health inequity, of all of those social determinants of health, what do you think the healthcare sector itself contributes to the well-being of our community? 25%. 75% of the things that make us healthy are outside of the healthcare system. That is early childhood development. That's education. That's housing. That's employment. All of those things are much, much more important. And parenthetically, as we grow in healthcare, remember that growth of 7%? You had to balance your budget. It had to come from somewhere. So where did it come from? Social services, early childhood development, housing, education, employment. So we parenthetically are making our population sicker by expending more in the acute care sector. So there's a challenge out there, I think, for all of us to meet. And so how unwell is our population because of inequity? Well, I think that there are pockets of our population that are so unwell, they are comparable to the life expectancies and health indices that I see in the developing world. The highest incident in the planet of lung cancer are in our Inuit population in Canada. The incidence of tuberculosis in our reserves is higher than where I work in rural Bangladesh. The life expectancy, if you drive from the richest part of Hamilton to the poorest part of Hamilton, it's about a anybody from Hamilton, they would tell me, but it's about a 15, 20-minute drive, I think. Drops from by approximately 21 years. The likelihood that you're going to get to the age of 75 in one of my shelters, 25%. The incidence of HIV/AIDS, where I work in Africa, about 18 to 20%. Amongst my injection drug users, it's 21%. Hepatitis C, it's 80%. Think of the impact that that's going to have on the healthcare sector when those people go on to progress to cirrhosis and hepatoma. So the challenges are massive, and the expenditures will be equally massive as our population becomes more diverse, the rich and the rich getting good services, reasonable access, the poor less so. So who are these individuals and why would they be having such a challenge? There are people in rural and remote settings. There are people who are disadvantaged, vulnerable, poor. They have mental health challenges. They have drug and alcohol addiction. They're physically disabled, refugees. They're very young. They're very old. So the challenge then, moving from there, is that our job? Well, you're a community hospital, and I think you've chosen that word very, very well. I think we're all part of a community, and I think that you have a responsibility as well for the well-being and health of the community that surrounds you, that you serve. And what are some of the challenges in that? Challenge is, how do you provide excellent quality care? Where's the research agenda in that? Where's the education agenda? But somehow our academic centers, of which you're one, we have to shift our mandate to be more siloed to integrated healthcare systems out in communities, serving communities. So that challenges us to move some of our care patterns out into that community. So I think what you're going to see in the future is acute care being part of an integrated health network. And I think that you're well on your way there, and you could easily serve to be leaders in that area and pave the way and develop some of the best practices models for others. So what that's going to look like is it's going to be patient-centered, integrated. There'll be new models of care. We're going to have to address chronic diseases, and we're going to provide care, the best care, when the patients need, when they need it, and where they need it. And that might not necessarily be within the bricks and mortar of the hospital around us. We're healthcare providers. We're healers. I agree. I understand that 100%. And that job is 110% of our time. But at the same time, I believe that we also have other responsibilities. And that's my challenge. I think we have a job to provide information for informed social policy decisions. I think we have to promote effective health delivery systems for prevention and care for all Canadians. I think we have to get involved in anti-poverty initiatives. I don't know anything about housing. I don't know anything about anti-poverty initiatives. I know everything about the consequences of not doing that. And so I think it's my job and all of our jobs to speak out on behalf of the communities around us who are voiceless, who are being ignored to a greater extent because of their circumstances, whether they're mentally ill, whether it's addiction, whether they live on a reserve or they're in a rural, remote setting. I think we have to affect positive social change through healthy public policy, and we have to spend time thinking about exactly what that means. And finally, I think we do have a job to advocate. We have a job to advocate for the values that are essential for health and the health of our communities and the health care for our communities. So Jerry's actively involved in the CanMed's role. That's one of those roles, is advocacy. And so I think that that's an important thing that we're all, our public look to us to do that. And by being silent, I don't think we're filling into our full potential.